Welcome, dear colleagues. I, Gursimran Kochhar, along with Dr. Michael B. Wallace, will now share with you our video highlighting the importance of retroflexion in the right colon during a screening colonoscopy. Colonoscopy is one of the most widely used procedures to detect and remove colon polyps. Removing polyps early is key to preventing colon cancer. Despite all its advances, colonoscopy can miss detecting polyps in up to 27% of the patients undergoing the procedure. Various strategies have been used to improve detection of polyps. Especially in the right side of the colon, it is suggested to have two looks in forward view to increase polyp detection rate. In addition, some people also advocate to retroflex the scope in right colon. Retroflexion is a technique in which we can turn the scope onto itself so as to see behind the folds. It is a technique routinely performed by endoscopists in upper endoscopic procedures and in the rectum during colonoscopy. One randomized clinical trial compared retroflexion in cecum to performing a second look. In this study, they enrolled a total of 1,351 patients. Retroflexion was successful in up to 96% of the patients enrolled in the trial. The polyp detection retroflexion group was higher at 30.5%. Moreover, the adenoma detection rate in retroflexion group was also higher at 26.4% compared to 24.6% in the forward view group. We hereby present a video in which entire colonoscopy was normal, except during retroflexion, we found a 1 cm polyp which was a sessile-serrated adenoma on pathology. We in our practice here at Mayo Clinic, Jacksonville, routinely perform retroflexion in cecum. So here we see the cecum along with the cecal base very clearly. The bowel prep in this patient is very good. We try to have a careful look, especially behind the ileocecal valve, to ensure we don't see a polyp. We then switch to narrowband imaging to see if there are any subtle lesions in the base of the cecum. We are now going to retroflex the scope. On retroflexion, now we see the opening of the IC valve, and right next to the IC valve, we see this polypoid lesion, which is about 1 centimeter in size. We see the stool sticking onto the borders of the polyp. The surface of the polyp is cloudy. These are characteristics of a sessile-serrated adenoma. Now we make preparations to perform a standard endoscopic mucosal resection. As the first step, we'll inject the base of the polyp with a methylene blue based dye. In this way, we ensure we separate the polyp from its underneath surface. Then we're going to exchange the needle for a standard snare. Using a standard snare, we're going to try to place the snare around the polyp to not only ensure that we get the entire polyp, but also to get some part of the normal mucosa around the polyp. Getting normal mucosa around the polyp also ensures that we get some negative margin. Now the polyp is nicely snugged in the snare, and now we're going to use electric current to cut the polyp from underneath his base. Once the polyp is cut, we're going to remove the polyp from the site and then carefully inspect the underneath surface. The entire polypoid tissue is removed. There was also seen a small polyp in the vicinity, which was also removed. The important teaching point in this case is that one should try and routinely perform retroflexion in the right side of the colon, especially cecum, in addition to the standard 2 looks which we routinely do to increase the yield of polyp detection during screening colonoscopy. Thank you.